Hi everyone, welcome to my presentation, OXIS Contacts, a 5-year journey. So the first picture shows, our university, the Sri Ramachandra University, and the second picture shows the entrance of our dental college. And these two pictures are, the pediatric dentistry department, a very child-friendly place. So we are actually the first dental team in the country to receive the Early Career Fellowship Award and Research Grant of 1,02,74,110 rupees from the Wellcome Trust DBT India Alliance. So Dr. Muthu sir is my fellowship supervisor. Vijay Mathu sir is my mentor. Dr. Justin Lee is our external sponsor, and Dr. Praveen Rajesh is our national collaborator. So this is our team. So today I'm going to tell you a little bit of what we studied on. As you can see, the first picture is the contact area, which is defined as the heights of contour of proximal surfaces of teeth. You can see proximal decay, which has affected both the first and the second primary molar. And this is a picture of a sectional model. Just wanted you to get familiar with a few terms before we go into the presentation. So first, let's start with what is known. Contacts have already been classified as open or closed, as you can see in both the pictures. The previous studies that have been done have classified the studies with contacts and proximal caries, but they were all cross-sectional in nature. So what is unknown? We do not know if there are other variations among contacts. We do not know the three-dimensional variations of them. They have not been studied at a three-dimensional level. Also, there are no prospective cohort studies in this area. So the research question of the present study is there an association between variations in contact types and proximal caries? To answer this question, we performed the methodology in 3 phases. Phase 1 was to propose a classification for contacts between primary molars. We wanted to know if there are different variations that we could study. For this, we chose already existing CBCT images. We did not expose any child to X-rays for this particular study. So I have just highlighted the area that we saw on the clinical image as well. So the total number of images that we saw were 76 CBCT images. And at the end of first phase, for the first time, we classified the variations in contact areas as the open or O contact, X or the point contact, I or the straight contact, and S or the curved contact, and hence proposed the classification OXIS. After successfully completing phase 1, we went on to phase 2, where we wanted to evaluate the prevalence of the OXIS contacts of children in a population of Puducherry. For this, we chose 1,119 school children who were completely caries free. So the total number of contacts we examined were 4,476 contacts of 1,119 school children. Depicting to you the clinical images of the 4 types of contacts: O contact, X contact or the point contact, I or the straight contact, and S or the curved contact. As you can see, the prevalence of the OXIS contacts, the most common contact was eye contact, which was present 75.5% of the times, and the least common was the X contact, which was present 3.3% of the times. Hence, at the end of this phase, we confirmed OXIS contacts clinically. After completing phase 1 and phase 2 successfully, we went on to phase 3, which was the major interest of the present research project, which was to evaluate the association between contacts and proximal caries. For this, all the 1,119 children who were recruited in phase 2 were followed up at 12 months, 24 months, and 36 months. At baseline, they were 3 to 4 years. So at 12 months, they were 4 to 5, 24 months for 5 to 6, and at 36 months, they were 6 to 7 when we completed this study. So we evaluated proximal decay as the outcome, and for that we performed a clinical examination at the schools, a questionnaire collection, because we know that dental caries had other confounders like oral hygiene and diet. And if there was a doubt with the presence of caries, we also performed a radiographic examination at the school premises itself. We all know that COVID hit us hard, so we had to tweak the methodology by also including home visits, clinic visits, and school visits. At the end of 36 months, we had 3,848 contacts of 962 children. If you remember, we started at 4,476. So if we see the Poisson regression analysis, which was done at different levels at tooth and child level, that the S contact had a relative risk of 22.5, which meant that if a child had an S contact, the risk of proximal decay was 22.5 times more than that of the open contact. Whereas this was followed by the eye contact, which had a risk of 12.7 times when compared to that of an O contact. And both the eye and the S contact was significant with a p less than 0.001. Depicting images to you of the same child and the same contact area at baseline 12 months, 24 months, 36 months. As you can see, the O contact has remained open. After this, let's move on to the X contact. At baseline 12 months, 24 months and 36 months, the contact remained caries free. Moving on to the eye contact, we can see that at baseline 12 months and 24 months it's caries free, but at 36 months there is decay with both D and E. And with the S contact, at 24 months itself there is decay at D, which has spread to both the teeth at 36 months. So mind you, all the children who were observed decay were offered free dental treatment with parental consent. Unfortunately, because this child did not report back for treatment, at 36 months when we saw her, the decay had spread to both the molars. So to conclude, OXIS is a risk factor for proximal decay, has been discovered as a new risk factor, and the order of susceptibility was S contact, followed by eye contact, followed by X contact, and followed by open contact. And this marked the success of the project, of the phases of the project at the at the planned timelines. Moving on to the outcomes, we published phase 1 in the Wellcome Open research with an impact factor of 1.77, phase 2 in pediatric dentistry, the clinical component, and phase 3, which was the prospective cohort component. The 12 months we published in caries research, and the 36 months has been accepted in pediatric dentistry, awaiting the proof. We had 8 other publications of this project, which were lateral publications, which was a retrospective cohort study for OXIS contacts and proximal decay, and also studied other anomalies like the prevalence of cusp of Carabelli and morphological variations, etc. We established 2 important collaborations at the end of this project. One with Children's Dental Center, that is with Dr. Justin Lee, where I spent 45 days for completing our data collection and research, and also completed a mini residency program. Our second collaboration was with Ajman University with Dr. Tarun Walia, where we performed a study where we compared OXIS contacts of Pondicherry children with Ajman. Moving on to the international awards, we received the Paul P. Taylor Award for Best Original Research in 2020, and again we were the first Indian team to win this. And the second international award was a Travel Award, which was received from the International Academy of Pediatric Dentistry for presenting a paper, and this happened in June 2023. Around 9 national awards for various reasons, like the best researcher, the Lakshmanan Gold Medal at our university, and 2 or 3 best papers, and also everything related to project, and also the best researcher. And the dissemination workshop, as we witnessed yesterday, so that is complete as well. So to sum up the outcomes, we have 12 papers, 1 classification, 2 collaborations, 11 awards, 28 invited talks, mainly how to motivate other dentists for funded research and also on early childhood caries, 15 conference presentations, and 1 dissemination activity. I cannot end the presentation without providing my gratitude to all the field workers who were rock solid, who supported me at every year for taking impressions, for clinical examination, etc. The parents of the children who agreed to be a part of the study, the school teachers who let me in the schools even during difficult times of COVID, and the Deputy Inspector of Schools who gave me the permissions. Forever indebted to my 1,119 children who gave me an opportunity to take care of their oral hygiene and their oral health for about 5 years. And along with this 1,119 children, there was also my child who was growing, who also was born at the start of the project and is now 6 years old. So to take home, dental caries is one of the most common chronic diseases seen in childhood. Despite the numerous efforts which is taken to curb this disease, the global burden of untreated decay in deciduous teeth accounts for 621 million children worldwide. Prevention is the key. At the end of our research, we have discovered a new risk factor for tooth decay in children. We are certain that if this risk factor, which is the variation in contacts, are detected early, it can lead to the prevention of tooth decay, hence decreasing the burden to a large extent. The International Caries Risk Assessment Protocol by the American Academy of Pediatric Dentistry and the International Association of Pediatric Dentistry may require modifications considering the tooth contact variations as an additional risk factor for proximal caries. Thank you very much for this opportunity, and I'll be very happy to take up any questions. Thank you.